Dear colleagues, I'm Dike Ojji. I lecture at College of Health Sciences, University of Abuja, and I'm chair of PASCAR Hypertension Task Force. It gives me great pleasure to welcome everyone to this webinar, which is jointly hosted by PASCAR. PASCAR is Pan-African Society of Cardiology, Hypertension and Preventive Cardiology Task Forces, and is supported by Omron. I'm sure you agree with me that the issue of hypertension cannot be overemphasized. Every one of us know that hypertension or high blood pressure is #1 risk factor for poor health all over the world today. And in our part of this world, it drives cardiovascular disease from heart failure to chronic kidney diseases to cerebral vascular accident, and also ischemic heart disease. Judging by the faculty we have, today, I'm very, very enthusiastic that it's going to be a very, very great meeting. Now, before I introduce the faculty, there are some housekeeping rules. The first one is that you have to post your questions to Judge Nell in the Zoom chat. The faculty will answer these questions at the end of the webinar. All delegates will be muted and their videos will be turned off. So next, I would like to introduce the faculty. Well, in no special order, I will introduce the person I will be giving the first talk. That is Professor Elijah Ogola of University of Nairobi. He's a professor of internal medicine and cardiology. Of course, obviously at the University of Nairobi, like I said earlier, and is the incumbent president of Pan-African Society of Cardiology. We'll be talking on awareness of hypertension in general. And next on the line is Professor Anastase Dzudie, who works at Douala General Hospital. He's the EBD past chair of Pan-African Society of Cardiology Hypertension Task Force. And we'll be talking of consequences or what we call complications of hypertension. And the third speaker is Professor Shameh Mohammed Shaheen. He's a professor of cardiology at Shaheen University. He's the chairman, cardiology department, Armed Forces College of Medicine. And he's also the past president of Egyptian Society of Cardiology. Currently, he's the chair of PASCAR Preventive Cardiology Task Force. We'll be talking on prevention and lifestyle in hypertension. That is his area of specialization. He likes lifestyle modification so much. And it'll be a delight listening to him. And then I will bring the fourth talk before the last talk, which will be given by Professor George Stergiou, who is a professor of medicine and hypertension at University of Athens, Greece. The council member of International Society of Hypertension. He's also the chair of the European Society of Hypertension Working Group on blood pressure monitoring and cardiovascular variability. Amongst others, is World Hypertension League Special Envoy for blood pressure measurement. His area of interest moves around home blood pressure monitoring. And he will be speaking actually on that topic on home. That takes us to the first talk, which will be given by Professor Elijah Ogola. Professor Ogola, over to you.
Thanks, Dike, for the kind introduction. May I take this opportunity to thank the PASCAR Hypertension Task Force for organizing this very important meeting, as you said, to Omron for kindly sponsoring this, and very importantly to our guest speaker, Professor Stergiou, for joining us in this very important meeting. My task today is the very pleasant task of simply setting the scene for what really is the main topic of today, which is monitoring of blood pressure. So over the next several minutes, I'll go over the state of awareness of hypertension globally, but also within Africa. No disclosures for the purposes of this presentation. And that is basically what I'll go through. One slide on the burden of hypertension, focus then on awareness rates, or rather more importantly, non-awareness rates, both in the global and African context, say a few things about some initiatives to raise awareness, and then conclude. So this is a slide that I would like to use, recently borrowed from our colleague Neil Poulter as part of the May Measurement Month, as it was used as the rationale for the May Measurement Month. And in one slide, it basically tells you what you need to know about the significance of blood pressure as a cause of morbidity and mortality. According to the Global Burden of Disease 2019, blood pressure is the biggest contributor to global mortality, leading to 10.8 million deaths each year. And this is bound to increase, as the global population grows older. Now, this is a slide from the NCD risk factor publication, which came out last year looking at various risk factors. And the prevalence of hypertension is given in terms of colors. To the left is for women, to the right is for men. And the darker the colors, the higher the prevalence of hypertension. And if you look at the continent of Africa, the prevalence rates range from, 30 to 50+%. So we have a very high prevalence of hypertension. According to the WHO, we have the highest age adjusted. But the more important thing also, which is not shown in this particular slide, is that we are one of the reasons in the world where there has been actually an increase in the prevalence of hypertension over the last 2 decades, with an increase of about 10 to 15% among men, both men and women. Now, this is a slide from a meta-analysis of various prevalence studies that had been done in Africa using the STEPS, the WHO STEPS instrument for doing cardiovascular risk factors, published now about 7 years ago. And it highlights the very significant lack of awareness of hypertension in Africa. So the blue bar here represents all people who are hypertensive, and that is at 100%. I'm not very good with colors, but the last bar here represents the proportion that is controlled, which is only 7%. And you can see here that the biggest deficit towards achieving control is the lack of awareness. Of every 100 people with hypertension in Africa, according to this meta-analysis, just over a quarter were aware of their hypertension status. And actually, when we make people aware of hypertension, the numbers that are treated are reasonable. It's more than 50% of those who are aware. So stressing the fact that probably the most significant effort towards population level control of blood pressure is making the population aware of their hypertension status. This is a data from our local Kenyan data, focused on the table on the right. This is from our national STEP survey that we did in 2015, published in 2018. And you can see that our data is actually slightly worse off than the data from the meta-analysis, in that we had an awareness rate of just about 15%. So literally more than almost 85% of the population living with high blood pressure were not aware that they had high blood pressure. Now, this is data looking at the world by various regions, published a couple of years ago. So on the top left is Latin America and the Caribbean. Top right is Europe and the Mediterranean. Bottom left is Southeast Asia and the Western Pacific. And the bottom right is our area of concern, which is Sub-Saharan Africa. And for each of those, the first bar represents all those who have got hypertension. The next bar represents people who have ever had a blood pressure measured. The next bar, which is of concern in this particular talk, is people who are diagnosed which means that people who are aware. And again, you can see that compared to the other regions of the world, we in Sub-Saharan Africa have got the lowest rates of awareness at an average of about maybe 20–25%. This is shown in a different way from, again, last year's NCD risk factor publication. So this is the global burden of hypertension. And the red bit here represents, if you like, the main iceberg, not the tip of the iceberg, of the entire burden of undiagnosed hypertension, which means that those who are living with elevated blood pressure, but they are not aware that they have elevated blood pressure. Again, these other figures show different parts of the world: high-income Western countries, Latin America, high-income Asia Pacific, South Asia, etc. Boxed here is Sub-Saharan Africa. And again, you can see that the orange or whatever the color is bar is particularly large in Africa, again, representing the fact that a big proportion of our population who have hypertension are not aware. On top of that are diagnosed but untreated, then diagnosed but treated, then treated but not controlled, and then controlled. And you can see that for Sub-Saharan Africa, that green sliver is really very tiny. So what are some of the reasons behind the lack of awareness? And one of the reasons is the fact that we simply don't measure the blood pressure of the population. So this is again data from the Kenyan STEP survey, which looks at the proportion of the population that have ever had a blood pressure taken. And this is a population from 18 years up to about 70 years. And you can see that overall, looking at both sexes, more than 50% of the population have never had their blood pressure taken. Men, as usual, do worse off than women. A whole 70% of men have never had their blood pressure taken. And the younger they were, the worse. So again, pointing to an area of intervention, which is opportunistic screening of blood pressure, which is something that I'm going to mention briefly towards the end. Now, this is a slide that Anastase will recognize because I've borrowed it from him, hopefully with his permission, which illustrates that even when we have our population that is in constant contact with the healthcare system, for example, people being followed up with HIV, this is work that he did in Cameroon in a population with HIV, that you would expect that would have regular blood pressure measurement, initiation of treatment, and attainment of control, and that this does not work. So what are some of the things that we can do to make the population aware? Obviously, multiplicity of things, including the fact that everybody who has got contact with the healthcare system has a blood pressure measurement. One of the global initiatives, as you are aware, is the May Measurement Month. And we in Kenya, like many African countries, have been participating in the May Measurement Month since 2017. We are currently doing the 2022 version, and these are pictures from what is going on currently. And this probably doesn't reflect very well, but this is a photograph from the northern part of Kenya, which is arid. And this gentleman who is disabled is being, his blood pressure is being measured while he's on top of a camel. So, like I said, we in Kenya have participated in May Measurement Month 2017, and this is data up to 2019. As we are all aware, 2020, there was no screening. The data for 2021 is not out. But in that period, we've screened more than 100,000 people. And there is a perception, which we hope is true. We can't prove it based on this data because this is opportunistic screening. But as a result of these initiatives, the rates of awareness seem to be better. They are clearly better than what we found in the nationwide survey. Another initiative that we've had in Kenya is something called the Healthy Heart Africa program, which I was involved in, which we carried out between 2015 and 2019. And cumulatively, as you can see here, towards the end, we screened about 6 million people. So we are calculating that if at least 50% of people generally have never had a blood pressure measurement, by screening 6 million people, we probably made at least 3 million new people know about their blood pressure status. Sort of in concluding, this is a figure that I've borrowed from the original World Heart Federation roadmap for the control of blood pressure, which basically says that, you know, towards controlling blood pressure, you have to get the people who have high blood pressure to know that they have their blood pressure, and that is the awareness. And that is really the beginning of this cascade of treatment, ensuring persistence in treatment and adherence towards achieving control. In conclusion, there is poor control of hypertension globally, but worse in Africa, and that this main barrier to the control of hypertension at the population level is actually lack of awareness, and that we should all work and make deliberate efforts to raise awareness, because really this is critical in the control of hypertension. Thank you very much for your attention.
Thank you very much, Professor Elijah Ogola. So over to you now, Professor Anastase Dzudie, as you talk about consequences of high blood pressure or complications of high blood pressure.
Thank you very much, Professor Dike, for giving me the floor. Before I start, I want to thank the organizers of this webinar for inviting my humble self. And I also want to thank Professor Ogola for his talk, because it actually settled the ground for my own talk. I also want to say that my understanding is that most of our audience is primary healthcare physicians. So I'll be talking more to the primary healthcare physicians. I'll probably not insist on studies, but rather on mechanism and what they will be seeing on the ground. So my own talk will focus on consequences of high blood pressure. And I have no conflict of interest for this talk. I just want to say that the objective of this talk is that they should be able to acquire knowledge regarding the most common complications of hypertension and principles of its effective management. So when we look at complications of high blood pressure, they are numerous. We won't be able to go through all of them, but I will take them through. I'll take them around with the heart, the brain, the kidney, some words on the eye, the blood vessels, and then we'll see what are the clinical evaluation of all of this and the implications. But of course, complications of blood pressure are really more than that. We have some acute complications like hypertensive crisis. There is CAD, there is heart failure, there is aortic aneurysm and dissection. But let's focus on what we've already said. So it is much more simple and much more contemporary to talk about hypertension-mediated organ damage. And this refers to structural or functional changes in the arteries or end organs. That's basically the heart, the brain, the eye, that's the retina, the blood vessels, or the kidney. And this is really a marker, most of the time it's a marker for preclinical or asymptomatic cardiovascular disease. I would say from the beginning that in terms of pathophysiology, the renin-angiotensin-aldosterone system, which, as we know, is the prime movers for most of the cardiovascular disease nowadays, and for the cardiovascular disease continuum, is once more the system that is going to be at the initial of hypertension-mediated organ damage. So it's because of all the effects of angiotensin II that we know either on the blood vessels or on the kidney or on the heart or on the adrenal gland or on the brain, that the majority of complications that will happen here will, of course, that will be described here will happen. So this, of course, let us know that if we block this system, then we might be able to either stop the progression of these hypertension-mediated organs, or at least to slow down the progression. So let's look at the heart in hypertension. Complications at the level of the heart can be either coronary artery disease or congestive heart failure or left ventricular hypertrophy, but I'm going to focus more on the left ventricular hypertrophy. So what happens with hypertension is that either because of the pressure overload, because the pressure overload, we can have myocytes thicken, and that can lead to concentric left ventricular hypertrophy. But on the other side, both with pressure overload and some volume overload, there can be instead myocyte lengthening, and that can lead to eccentric left ventricular hypertrophy. If it happens that there is an infarction, maybe because of coronary artery disease, then this will lead to a mixed load and post-myocardial infarct remodeling, and this can lead to left ventricular hypertrophy too. But in this case, usually the left ventricle dilates asymmetrically, and this will lead to heart failure. So one of the key slides when it comes to progression of hypertension from uncomplicated hypertension to LVH and heart failure is this one, meaning that hypertension can either lead to LVH itself, which will lead to early phase of diastolic dysfunction and then later congestive heart failure, or it can go through MI and then systolic dysfunction, and that will also lead to congestive heart failure, and all of this leading to death. Of course, it is not just as simple as it is presented in this slide, but this is basically what primary healthcare physicians need to know. This takes time. It is not just going to happen in some few days or months, but it really takes several years to occur, so that by the moment we are seeing a patient with an acute complication, then hypertension has been there for quite some time, and this could have been prevented. So what will you see if you do an electrocardiogram to these patients? There are two main criteria that will actually let you know that there is LVH. Either the Sokolov-Lyon, which is S in V1 plus R in V5. If it is above 35 millimeter, then you suspect LVH. Or the Cornell criteria, which is mostly used as S in V3 plus R in AVL. And if it is above 28 for men or 20 for women, then we talk about LVH. We can also look at the R in AVL, and if it is above 11, then that's also suggestive of LVH, or we can also look at the Cornell product. So if you send the patient to a cardiologist, then an echo can be made if there is an indication, and therefore the cardiologist will calculate the LV mass. And if the LV mass is above 95 grams per meter square in women, or 115 for men, then that means there is LVH2. But besides LV mass index, we also look at the relative wall thickness, which actually tell us more about the geometry of the left ventricle, because that helps calculating the relative wall thickness at two posterior wall thickness divided by left ventricular end-diastolic diameter, and that tells us more about whether the ventricle itself is, the left ventricle itself is normal, or whether there is concentric LVH, which means that there is an increase in relative wall thickness as well as in the left ventricular mass index. Or it can happen that there is increase in left ventricular mass index, but relative wall thickness is normal, and that's eccentric hypertrophy. Or at times it can also happen that instead the relative wall thickness is high and the left ventricular mass index is normal, and that's a concentric remodeling. So left ventricular hypertrophy is an independent risk factor for stroke. As you can see on this slide, people with LVH will present with more stroke, more heart failure, and more coronary artery disease as compared to their counterpart without LVH. So left ventricular hypertrophy should be tracked, and it should also be treated aggressively. We demonstrated in a very small study in our setting that this occur, especially left atrial remodeling, left atrial enlargement, occur at the very early phase at the moment we diagnose people with hypertension. So if we compare here control with hypertensive people at the moment of the diagnosis, then as you can see here, there is high levels of high risk of left atrial enlargement in people with hypertension. And some of them already present with severe left atrial dilation at the moment of diagnosis. Now let's look at the brain in hypertension. Now when it comes to brain and hypertension, one of the key things to know is that it can be responsible for both ischemic stroke or intracerebral hemorrhage or subarachnoid hemorrhage. Most of the time, it will tend to be responsible for ischemic stroke. But this is not very much, so most of the ischemic stroke will present with mild symptoms. So they don't usually come to the hospital, or at least they don't come immediately. And it is rather those with hemorrhage that will come immediately. So that's why the hospital will tend to think that intracerebral hemorrhage is the most frequent complications of hypertension. Hypertension is really associated with an increased risk of stroke occurrence and mortality, whatever the level of blood pressure. As you can see here, starting from blood pressure as low as 115 millimeter of mercury, the higher the blood pressure, then the higher the chances of occurrence of stroke and the increase of mortality. And this also increases, of course, with age. It is important to understand that at the early phase of stroke, there are some cells, some neurons that will be dead. But around those neurons that will be dead, there are other neurons that will just be suffering, but not yet dead. And if the intervention occurs very, very early, then it is possible to save these cells of the penumbral zone. So that's why it's important to take this, to take care of these patients at their very, very early phase. What are the signs of and symptoms that they will present? Some of the signs and symptoms they will present with, in terms of symptoms, will be acute onset of focal arm or leg weakness. They can present with facial weakness, but it always has to be distinguished with Bell's palsy. There can be speech or swallowing difficulties. There can be vertigo, visual disturbances, reduced consciousness, vomiting, and severe headache. When it comes to physical examination, there are two types of signs we will seek for. If it is anterior, if the stroke is affecting the anterior circulation, then we will have usually hemiparesis, which can be proportional, hemiplegia, or neglected side of the body, or aphasia or visual field defect. But if it is posterior, then diplopia vertigo, limb and gait ataxia can occur, or facial paresis. But other signs like Horner syndrome, dysphagia, dysarthria, and sensory loss should also be investigated at the clinical exam. Tests that will be done at the very early phase, you will rather give privilege to MRI or serial multimodal brain CT. But if the patient comes after 24 hours, really what is important to do is to go for a CT scan just to exclude hemorrhage. That can be life-saving, especially if you are going to use antiplatelets or anticoagulants. It will be good to be sure that there is no hemorrhage. So this slide shows what occur at a very early phase. There can be some subtle blurring or gray-white. It can be difficult to see at the very early phase, but as time goes, there is going to be increase in the gray-white, and that would tell us that that there is an ischemia, and that is usual. That usually respect the zones of the arteries. Now, when it is a hemorrhage, it is much more easier to identify because of the hyperdensity, which once more will be respecting the vessel distribution of the brain. And when it is a subarachnoid hemorrhage, we have some white densities like this, which is much more diffuse, and that usually goes also with the clinical syndrome. So first step in hypertension and paralysis in Africa, I would say the first thing to do is an immediate referral to stroke center. If there is no stroke center, if you have no access to a stroke center, then refer for an emergency CT scan, because that's what is going to tell us what to do next. And if possible, then the patient can be referred where a neurologist is. But please do not give aspirin or any antiplatelet or any anticoagulant if you don't have a CT scan. Now, the kidney in hypertension. Hypertension is actually the second most important cause of CKD after diabetes. And as you know, when hypertension is diagnosed, creatinine is always requested. And from the creatinine, then you can calculate the eGFR, either using MDRD, which is available, or using the Cochrane. But we must really plead for MDRD. And if this is calculated, then you can classify your patient in accordance to the eGFR. And it's important to know that once there is an alteration in the GFR, starting from stage 2, it is good that if you have access to a kidney specialist, if you have access to a nephrologist, then it will be good that the nephrologist sees this patient so as to really understand the matter and ensure that we really slow down the progression from the early stage to the stage of the dialysis. Now let's look at the eye in hypertension. As we've said about the heart, the brain, and the kidney, there are also some adaptive changes in the arterial and arteriolar circulation in response to high blood pressure at the level of the retina. And this can, most of the time, it doesn't lead to any visual symptoms. However, some patients may report some decrease in vision or headache. The prognostic significance by fundoscopy has been well documented, and usually it's classified in accordance to what is seen on fundoscopy. But what I want to say is that at the early stage of grade 1 and grade 2, these generalized or focal arteriolar narrowing are not very specific to hypertension, and there is a weak association with stroke and other hypertension-mediated organ damage. But once it is either grade 3 or grade 4, then there is a strong association with hypertension-mediated organ damage, and stage 4 is very much associated with mortality. So it's important to look at these signs. This is how it will appear at stage 3, and we can see here some hemorrhage as well as we can see here some exudates. And at the stage 4, where there is usually an optic disc edema or a macular star, then it is very much, as we have already said, associated.
Sorry, Anastase, you have 2 minutes more.
Yeah, thank you very, very much. So I'll just say something on the blood vessels in hypertension, which is a major risk factor for PAD. And I also mentioned that carotid intima media thickness is, it can also be assessed. And it can also, PAD can also be grade. And the higher the grade, then the higher the alteration in the arterial, in the arteries of the leg, and the importance of treating aggressively. This is usually assessed using a Doppler ankle brachial index. What is about the clinical evaluation? I would say a 12 electrocardiogram is recommended in all patients. Echocardiography is recommended if there are signs or symptoms. The creatinine should always be done to investigate for the kidney. Fundoscopy is usually, it's always recommended in grade 2 and grade 3 hypertension. And then brain scan or MRI depends on the symptoms. What are the implications? The implications are that even for some low level of blood pressure, once there is already presence of hypertensive mediated organ damage, then this should lead to medications. And when we talk of medication, we talk of blocking the renin-angiotensin-aldosterone system. So I'll now conclude by saying that hypertension-mediated organ damage is frequent, with main involvement at the heart, the kidney, and the brain. And that this may be asymptomatic for long, but should be detected using a simple test, as we've seen. And that the assessment may play a role in stratifying the risk of patients and influencing the decision for treatment. And that ACI and ARBs must be favored in hypertension-mediated organ damage. Thank you very much. Thanks for your attention, and I remain available.
Thank you very much, Anastase, for keeping the time. So my pleasure now to invite Professor Shaheen to talk about lifestyle in hypertension management. Okay, so hello, everybody. My name is Shaheen. Thank you very much for the invitation. I'm delighted to participate in this meeting, in this important meeting. Actually, my task is to talk about a very important aspect of hypertension management, which is what we call lifestyle modification or non-pharmacological treatment. In fact, lifestyle modification should start once hypertension is diagnosed with medications, and even before the diagnosis of hypertension, to prevent the occurrence of hypertension. So, through updates, what's new in this important domain, which is the lifestyle modification and its relation to hypertension. First of all, I would like to remind you with the major determinants of hypertension, and that it can be classified into what we call the environmental factors that include the unhealthy diet, the intake, the low potassium intake, the physical inactivity or lack of physical activity, and the overweight and obesity. And these environmental factors are what we call the lifestyle of the patient. This is to be compared to the genetic determinant of hypertension, which is inherited in the genes of hypertensive patients. And of course, some of the patients may have both contributing determinants in the same at the same time. And of course, we have also the social determinants, like the level of wealth or income. And this is has been quite an important aspect of recent research. The level of education, the occupation of the patient, and of course, healthcare. So these are the environmental factors that can impact the health of a hypertensive patient.
Most of these factors are related to what we call the westernized mode of living, where people tend to have sedentary life, more inactive life, even patterns tend to change to more caloric diet, lack of processed meats, alcohol, sugar, refined grains, and ultra-processed food, high sodium to potassium ratio, and disruption in the with their sleep-wake-up cycle, and eating pattern, physical inactivity, and high screen use at night. All of these are signs, of course, of modernization and westernization of our habits of living, which sometimes are harmful to our patients. They increase the hypertension adiposity levels, glucose and insulin levels in blood, the blood lipids, inflammation, and the SNS activity. Most of these factors are actually interacting with many dominant causes of hypertension, like activation of the RAS system, the insulin, increasing the insulin resistance, developing some sort of vascular dysfunction, and promoting inflammation and causing dysfunction of the autonomic nervous system. And as I mentioned, that every one of these factors of these abnormal or unhealthy lifestyle may act in more than one mode. And at the very end, they increase the blood pressure in various modalities. I have this very interesting study that compared lifestyle interventions for the prevention and treatment of hypertension compared to genetic factors. Actually, this study included more than 277,000 individuals, and they made a genetic risk score according to the number of genes causing hypertension from the UK. And at the same time, they did scoring to the lifestyle factors to the patients. And by these two scores, they were compared, and they proved that the healthy lifestyle score was strongly inversely associated with both systolic and diastolic blood pressure, irrespective of the underlying blood pressure genetic risk. So it seems that these data support population-wide efforts to lower blood pressure through lifestyle modification. It seems that lifestyle modification is actually more important than non-modifiable genetic risk for development of hypertension. That's the point of this lifestyle factors that we are talking about. Again, study in China, it showed that in addition to antihypertensive medications, adopting a healthy lifestyle is associated with benefits in the prevention of premature death among individuals with hypertension. And as you can see here, that the higher the healthy lifestyle score, the less is the hazard ratio for all-cause mortality or cardiovascular disease mortality. So the style of the patient lower the risk of all-cause mortality or cardiovascular disease mortality. And this study was published in China. You have to remember that most of these a modest impact on reduction of blood pressure, but modest, but yet important, that, as you have seen, can cause reduction in mortality. So reduction in body weight, you can expect a reduction of 5 millimeter mercury. Diet with plenty of fresh fruits and vegetables, whole grains, low-fat dairy products, and reduced saturated fat, you can expect a reduction of almost 10 to 11 millimeter of mercury. Reducing sodium in diet, 5 to 6 millimeter reduction. Increasing the dietary potassium you can reduce the blood pressure by 4 to 5 millimeter mercury. All types of exercise, whether we are talking about aerobic, dynamic resistance, or isometric resistance, will reduce the blood pressure again modestly. Reduction will reduce the blood pressure. That's why all the guidelines has adopted this evidence A recommendation to adopt lifestyle intervention. This is the latest recommendations of cardiology guidelines. You can see action should be less than 5 grams per day, and your sodium should be less than 1 gram, and salt restriction less than 5 grams. That's 1/5 of a teaspoonful of salt, and it is a class 1 recommendation. To restrict alcohol, to increase the consumption of vegetables and fresh fruits, to reduce the weight, regular aerobic exercise, 30 minutes of moderate dynamic exercise, 5 to 7 days per week is recommended, and of course to smoking cessation. This is the same, exactly the same with the American College of Cardiology recommendations, the same level of evidence A recommendations. So really very strong recommendations for lifestyle, as I mentioned, with or without pharmacological treatment. If the patient is having mild hypertension, the modification of the lifestyle might suffice, might be enough. But if the patient is having moderate to severe hypertension, definitely treatment is on top of lifestyle modification. And this very recent study has mentioned that we are perhaps we are not going to prescribe the exercise as generic advice, but in fact it will be personalized according to the level of the blood pressure. So this is the future of prescribing exercise. It should be personalized according to everybody blood pressure or body mass. PASCAR has been very active in this regard, and this is an important paper, a roadmap for management of hypertension in Africa. And as you can see, these are very important 10 points as a recommendation for African countries in order to manage, prevent, and treat hypertension, if you wish. On the ground, I will revise with you some of the recent data about how the lifestyle management is effective in African countries. This is a paper from Eastern Ethiopia, and it showed that the knowledge and attitude toward lifestyle modification recommended for hypertension management was fairly good, poor. This was the conclusion of this paper. Similarly, in Nigeria, the lifestyle modification is widely prescribed for the treatment of hypertension, but rarely prescribed for its prevention by the general medical practitioners in Nigeria. And we know that it is active and it is important in both treatment and prevention. In Zimbabwe, again, that showed that adherence to the recommended lifestyle behaviors, which are known to be effective in controlling blood pressure, was poor. Of course, expected in our Zambia and Malawi. Both of them showed a high level of patients or people not consuming 5 servings of fruits. So 78% of the studied patients consumed less than 5 servings of vegetables. In Malawi, the percent was 54%. In Egypt, 90% of the population in the steppes consumed 5 servings, 90%. And the problem in the females was obesity. 48% of females were obese, and the problem in males were smoking. Almost 43% of males were smokers, and these were, of course, very high levels compared to countries. What I want to highlight in this regard is that preventing and treatment hypertension depends on 2 main pillars. The first one is the highly based strategies to diagnose hypertensive population and to treat them, whether hypertensive medications or with lipid-lowering medications to reduce the cardiovascular risk. But as equally important is the public health or the community-based strategies, like the community-based smoking cessation strategies, the diet, the healthy diet, and reducing the salt in the community, and increasing the exercise. Very important.
Sorry, Professor Shaheen, you have 2 minutes. 2 minutes more, please.
Yes, yes, thank you, George.
Thank you.
And the recommendations was also by the WHO. A lot of initiatives was recommended, including reduce salt. And this is a very important initiative in Egypt called the 100 Million Health. And it actually, the importance of this initiative is that it surveyed almost 50 million of the population, Egyptian population. It was first initiated for virus C, hepatitis, but included the blood pressure and the sugar. So this was large-scale screening and integrated health workers other than doctors. So this is task sharing, which is recommended again by the WHO, and it proved to be very helpful in reducing the blood pressure. I want to end by the fact that these lifestyle modifications are actually not costing very much in the budget of health. And if you compare it, the population-based intervention compared to the best buy, the individual-based intervention, it's only a small contribution compared to the individual-based contribution, and it is cost-effective. So I would like to summarize, conclude by the fact that lifestyle modification is a potent intervention, and then implementation of lifestyle modification is more challenging than pharmacotherapy. Unhealthy lifestyle remains the most neglected aspect of hypertension. Support high-quality research on effective implementation strategies for healthy lifestyle strategies. This is our recommendation. Promote task sharing and expand scope of practice to include all health workers, because we have a lack of a good number of health workers. So we have this and other health workers in this important task, and definitely invest in community-wide lifestyle policies that prove to be cost-effective. Thanks very much for your attention. Thank you.
Thank you very much, Professor Shaheen, for keeping to time. So that takes us to the fourth lecture that we just come before our guest lecturer, Professor Stergiou, comes up. As I will be taking that, I will be talking about treatment of hypertension in Black. So what is peculiar? Sorry. So what is peculiar to the treatment of hypertension in the Black population? So these are my disclosures, and it does not conflict with this meeting in any way. Professor Gola showed this earlier, and one thing we can learn from this data from WHO, that the African region has very high burden of high blood pressure in persons that are 25 years of age and above, and that is for both males and females, as you can see by this data, with some of the prevalences getting up to about 55% in some of the cases. Now, this is the data from the US National Health and Nutrition Examination Survey. One important thing here is that hypertension-related cardiovascular renal complications like stroke, left ventricular hypertrophy, these are things that Anastase has mentioned, heart failure, and chronic kidney insufficiency tend to occur more in Blacks compared to the white population. And also, when you look at the death rate in Black compared to the white population, it was found from that survey that in the Black population, it is 51 to 100,000 population in terms of mortality due to high blood pressure, as against 15.1 in 100,000 of the population. And when you compare the female, it was 40.9 to 100,000 population in the Black women compared to another 15.1 in 100,000 of the population in white women. It's also been noted that hypertension-related eye damage tend to be more common in Black patients compared to white patients. And there also tend to be strong correlation of uric acid levels to hypertension. It's been seen in some studies that uric hyperuricemia tend to predate hypertension in some population in the African region. This is a study that was carried out in the United Kingdom. And here they compared the Black population, actually African immigrants, compared to Caucasians. And one of the things about this is the fact that for the Black population, they tend to respond better to calcium channel blockers and diuretics compared to the white population or the Caucasians. And the reverse is the case when you compare the RAS blockers and the beta blockers, with the Caucasian population responding better to these agents compared to the Black population. And this was when they were considered as monotherapy. Now, this pattern has earlier been shown in two studies. These are old studies. One was in South Africa by Professor Sareli, and another one by Professor Digun in Ife in southwestern part of Nigeria. And for the study in South Africa by Sareli, what he showed was that monotherapy with calcium channel blockers, specifically nifedipine and verapamil, were more efficacious compared to monotherapy with hydrochlorothiazide and with enalapril. And for the study in southwestern part of Nigeria, they showed that nifedipine as monotherapy was more efficacious compared to thiazide diuretics. The same has been replicated in Cameroon by Anastase, who is one of our faculty here, and it showed that calcium channel blockers are the most commonly prescribed antihypertensive in 408 of the patients they studied, and 60% of those that were on monotherapy, mainly of calcium channel blocker, achieved blood pressure control. Another thing they found in that study that over 95% of their patients needed 2 or more medications to get their blood pressure to go. And in this review by Bresta in 2016, they also show that calcium channel blockers followed by diuretics are the most preferred antihypertensive medications as monotherapy in the sub-Saharan African region. And they went further to show the effect of calcium channel blockers and diuretics when compared to the RAS blockers and the beta blockers. And you can see that calcium channel blocker were the most efficacious as monotherapy, reducing blood pressure, systolic blood pressure by 12.1 millimeters of mercury, followed by diuretics by 11.81 millimeters of mercury. In our study of over 265 patients in the Federal Capital Territory of Nigeria, that is in Abuja, we've shown that just like Anastase showed, that most of our patients require 2, 3, 4, or a few of them 5 or 6 medications to get their blood pressure to go, meaning that over 95% of them needed combination therapy. And the most prescribed antihypertensive medications classes were calcium channel blocker represented by 1, followed by diuretics represented by 2. Now, the CRUISE study, which to date is the largest randomized controlled trial of antihypertensive agent in the Black population, whereby we compared amlodipine and hydrochlorothiazide versus amlodipine and perindopril, and then the last arm being perindopril hydrochlorothiazide, went further to confirm this, with the amlodipine combination being more efficacious than the perindopril hydrochlorothiazide combination. In fact, they reduced mean 24-hour ambulatory systolic blood pressure by over 3 millimeters of mercury. And this was also seen even when these values were unadjusted, and also for office blood pressure measures. And this review clearly states it further that there is all rationale to promote calcium channel blockers as first-line agents in initiating initiation of combination therapy in the Black population. And so what do the guidelines say? The International Society of Hypertension guideline states that, of course, there's increased cardiovascular risk, just like we have seen in that survey in the African Americans compared to the Caucasians. But they also went further to say that thiazolide diuretic with calcium channel blockers or calcium channel blocker with angiotensin receptor block, or rather with the RAS blocker, should be choice. So calcium channel blocker should be central in the management of hypertension in Black population. And the 2018 European Society of Hypertension guideline also recognizes the calcium channel blocker either in combination with a RAS blocker or with a diuretic in the management of high blood pressure in that population. So what drives this? Professor Shaheen has alluded to this, that there are two things basically. One of them is genetics. Of course, another one is environmental factors. And it seems that environmental factors tend to, in a great way, modulate the genetic effect. And this is seen clearly in this study by Professor Reina in University of Cape Town. And it's shown that even for normotensive individuals, even when they are young, when you compare the plasma renin activity and their aldosterone levels in Blacks and the white population, the white population tends to have higher level of plasma renin activity and also aldosterone. And this is further illustrated in what is called the Leaders variant, which is also called the R5C3Q mutation. This mutation is associated with low renin and low aldosterone hypertension in Blacks and not in white South African. And the other thing about it is that it's also associated with hypertension within kindreds. And it also responds to treatment with amiloride, which unfortunately is not used as single agent in most African countries, apart from in what we call nomoretic or moderatic, where it comes in with hydrochlorothiazide. So as I conclude, one thing about hypertension in the African population or the Black population is the fact that there seems to be intermingling between genetics and social factors, just like Professor Shaheen has pointed. And those genetic factors tend to affect how this population responds to antihypertensive agents. We've seen before that the calcium channel blockers and the diuretics are more efficacious as monotherapy compared to the RAS blockers or beta blockers in this population. But we should not also overlook the fact that treatment and stratification of this group is very, very suboptimal. And that calls for the fact that we need more advancing research efforts to actually be able to study, the pattern of hypertension, and also maybe in the future, look at novel therapies that will help the hypertensive African patient. So these are my take-home points as I conclude. Hypertension-related cardiorenal complications tend to occur more in Blacks than in white population. Calcium channel blockers and diuretics, and when we talk about diuretic, we're talking about thiazide and thiazolide diuretic, are more efficacious in Black patients as monotherapy compared with the RAS blockers and the beta blockers. Evidence shows calcium channel blocker-based combination should be preferred to diuretic-based combination in the treatment of hypertension in this group. Hypertension in the Black population is driven by a combination of genetics and environmental factors. Thank you very much. So now, thank you. So we now go to our last lecture, which happens to be the guest lecture. We are very pleased to have Professor George Stergiou, all the way from Athens, Greece, and incidentally speaking on the topic which he has worked so much on all over the years. So, sir, we are very pleased to have you. So the floor is yours. Thank you.
Thank you, Mr. Chairman.
Right.
Many thanks for this opportunity to contribute to this important meeting on hypertension. And thank you for asking me to talk about whole blood pressure monitoring, which is one of my favorite topics. This is my declaration of potential conflict of interest in relation to this talk. So this is a paper we published 12 years ago in the Hypertension Journal. And the main message is that we said that it's time to take this method seriously. And in fact, the European Society of Hypertension takes home blood pressure monitoring very seriously. Last year, we published practice guidelines, not theoretical knowledge about blood pressure measurement methods, but what doctors need to do, not to know, but what to do, how to apply the methods in clinical practice. And this was not really a European initiative, because the authors here were around with the world from Australia, Japan, China, America, and many other places. Also, the European Society of Hypertension last year published a very long paper exclusively focusing on home blood pressure monitoring, where you can find all the knowledge and information we currently have on this method. The reason why we put so much focus is that even if you have very careful measurements of blood pressure in the office or clinic, if you measure out of the office using ambulatory monitoring or home blood pressure monitoring, you can find with most methods a considerable proportion of people having blood pressure only in the office, white coat phenomenon, and some people with low blood pressure in the office and elevated out of office, mass hypertension. And you can see these misleading cases in the office are something like 25%. But even if you look at the treated patients in our clinic, white coat and mass hypertension using ambulatory home monitoring are almost 1 out of 3 patients, even with carefully taken office measurements. And this is important to diagnose because we have prognostic data. You can see here the IDHOCO database, 6,000 people outcome data, 8 years follow-up. And you can see in untreated people, the white coat hypertension has similar prognostic value as normotension, and in treated people, actually the same prognostic value. But you can see here mass hypertension is a little superior to uncontrolled hypertension, but particularly in the treated people, mass hypertension has even higher risk than uncontrolled hypertension. This is because the doctor does not see the elevated blood pressure in the office. So it is important to diagnose these intermediate phenotypes. One very important issue, which have been already discussed by previous speakers, is the long-term adherence to treatment for hypertension. And home blood pressure monitoring has been shown to be one of the few methods that improves patients' adherence. This is a review of 24 randomized controlled trials that shows that those people who self-monitor their blood pressure at home have a considerable, small but consistent benefit in having better adherence and better control rate. And in the total population of hypertensive people, this might have an important impact on cardiovascular disease prevention. What about the cost? What one might say, well, we have to pay about the devices and the maintenance and so on. And here's a study where we compared the classic office and ambulatory method versus home measurement alone. And you can see you have some benefits because you escape the office visits, but you have to pay for the device. But in the long term, it is cost saving, not only life saving, but also cost saving to use home blood pressure monitoring. It's less expensive when you have less office visits and you don't use ABPM. Of course, ABPM is regarded today as the best method to diagnose hypertension, and the most important advantage of the method is its ability to measure nighttime blood pressure, which we think is important. But here you see in one study we published 10 years ago, where we showed that you can use low-cost home monitors equipped with a function that takes automated measurements during sleep. And either using 24-hour ambulatory monitoring or low-cost home devices that measure blood pressure during night sleep, you find similar values for daytime and nighttime systolic and diastolic blood pressure, and a very good agreement between home and ambulatory monitoring in detecting non-dippers. If you think 74% is not enough, if you do ABPM twice, the reproducibility of the diagnosis of non-dippers is about 75%. And here is a meta-analysis of studies from Japan, from Greece, and from Finland, where it showed that home nocturnal blood pressure and ambulatory nocturnal blood pressure have the same ability in predicting left ventricular mass index induced by hypertension, left ventricular hypertrophy. Another very important aspect of the method, which we often forget, is what patients prefer. And this is one study in Scotland on the left and one in Greece. And these countries are different because in Scotland, very few people use home blood pressure, but in Greece, most people do. And these countries with different use of home measurement, you can see in Scotland, 80% of the patients preferred using home blood pressure monitoring rather than 24-hour ambulatory monitoring. 20% of people preferred 24-hour ABPM. And they found it more comfortable to perform home rather than ambulatory monitoring. And in the study in Greece, when we asked them how easy was to perform the two methods, most people said home blood pressure monitoring is easier to perform, and people preferred home monitoring in their next assessment rather than 24-hour ambulatory monitoring, at least most of them. This is why this major figure in ambulatory monitoring, Tom Pickering, actually several years ago called for action to reimburse home blood pressure monitoring. He said at that time that home blood pressure monitoring has the potential to improve the quality of care while reducing costs. Home blood pressure monitoring is a valuable tool for research. And I'm very happy to see that in the last 10 years, but only in the last decade, several investigators realized the value of using home blood pressure monitoring in their research trials. So let's say that you want to compare the antihypertensive efficacy of two drugs, and you aim to find a difference, if there is one, of 5 millimeters mercury. Then if you want to have a 80% power, which means 80% chance to find the difference if there is one, then if you use clinic blood pressure measurement, you can see here the power of your study is something like 65%. 65% chance to find the difference in efficacy between the two drugs. But if in the same study use ambulatory monitoring, you have something like 85% power, and with home monitoring, almost 90%. So home blood pressure monitoring improves the statistical power of clinical trials. But home blood pressure measurement has a very weak point, and this is the reporting bias, because several studies have shown that our patients select which of their home readings will show to the doctor. This doesn't mean that they cheat, but they believe that some readings are not representative and they tend to discard them. And this happens with whatever patients monitor at home. Glucose, oxygen, they always select what they are going to show to their doctor. So, ladies and gentlemen, if we are going to use home blood pressure monitoring to define treatment, to decide long-term treatment for 1, 2, or 3 drugs, to detect white coat and MASH hypertension, we cannot rely on this kind of selected biased information. But today, technology can help us eliminate this important bias by using electronic devices which automatically save and average all the readings and send these numbers to our computer, to our smartphone. So home blood pressure telemonitoring is the 21st century solution for hypertension evaluation. And you can see here several systems, quite low cost and long-term maintenance, reliable devices that can take all the measurements, store them, average them, provide them in an unbiased, straightforward way. And you can see here a system where you take the measurements, and these measurements automatically are transformed from the device to mobile. You can see them, you can average them, you can send them to your doctor. This is the way for the doctor to have a reliable picture of the blood pressure behavior of his patients at home. And the system can give graphs and averages for weeks, days, or even months. So there is a lot of emphasis on the home blood pressure telemonitoring, and this is a meta-analysis of 23 randomized controlled trials. And the conclusion is that this method may represent a useful tool to improve hypertension control, still quite costly versus usual care. But you know, the cost of technology is going down, and the efficiency is improved. And it's very interesting that the COVID-19 pandemic was a great opportunity for expanding home blood pressure monitoring. You can see here projects in the United States, in China, in Italy, where doctors were forced to use home blood pressure telemonitoring because it was the only way to get information of the blood pressure of their patients. And the International Society of Hypertension actually presented a statement 1 month ago showing the potential of the virtual manager of hypertension and the lessons we got from the COVID-19 pandemic. And you can see here, the International Society of Hypertension proposed 3 models: a basic model for low resource settings, advanced care, and more complete care. And in all these systems for patient management in virtual way, the center is home blood pressure telemonitoring. But it is interesting to realize what is happening with home blood pressure monitoring in practice. This is a study from Spain, which looked at the opinion of 2,220 physicians on using home blood pressure monitoring and ambulatory monitoring. I can tell you the similar findings could be found in our country, in Athens, in Greece. And you can see here in Spain, 67% of the doctors said they use home blood pressure monitoring always or usual, compared to 30% for ambulatory monitoring. Ambulatory monitoring is not going to be a solution for most of our patients, even in high-income countries. Home blood pressure monitoring is the solution. But there are barriers for using home blood pressure monitoring, and I'm showing you here data from United States. So what do American doctors in primary care see as barriers to using widely home blood pressure monitoring? So they said they have some concerns that patients may not measure correctly, but it's up to us and the technology to guide people to do the method properly. There are concerns that patients may become preoccupied with blood pressure. And also this is up to the healthcare professionals and training to the patients. 95% patients can be trained to use the method perfectly. Of course, there is another problem with device affordability in some populations, but and this is an issue, but it's good to say that the devices, reliable devices, have now decreased their costs. But in one important concern, which we should seriously discuss, is that many healthcare providers lack confidence in their skills and knowledge how to interpret home blood pressure monitoring. This is our responsibility to make sure that primary care doctors know how to use and how to interpret these readings. So let's see what the guidelines say. The guidelines recommend to use home blood pressure monitoring for initial diagnosis, to confirm hypertension, to detect white coat and mass hypertension. For treated hypertension, the guidelines say use it in all treated hypertension unless they're incapable or not willing to perform in good quality or they're anxious with self-monitoring. Very few patients. Use it to identify white coat and mass hypertension, to titrate treatment, to monitor long-term control, to improve patients' compliance. For devices, the European Society recommends electronic upper arm cuff devices which are properly validated. We prefer devices which have automated storage and othering, or mobile phone, PC, or internet connectivity. And you can see here how technology is helping us, is giving us simple, easy, and unbiased solution. Look at this device, no cables, just something to put on your arm, press the button, and the measurement is automatically transferred in your mobile, and all readings are averaged to send to the doctor. A very practical, a very easy, a very unbiased way to inform the physician on how blood pressure behaves on his patients at home. And don't be confused about these devices. These are wrist devices, but not cuffless devices. This is the last word of oscillometric cuff blood pressure measurement. Both these devices have a small cuff. They are sophisticated oscillometric wrist devices. These are quite tricky to use because these are not only home monitors. You can use them at home, but you can use them at work and other places. So STRIDE-BP is an international organization which is supported by the European Society of Hypertension, the International Society of Hypertension, and the World Hypertension League, and provides lists of accurate devices to guide physicians which device to select. And unfortunately, the STRIDE-BP was able to recommend only 8% of the blood pressure device on the market. And there are lists of other devices or aggregate devices to use for home, for office, for ambulatory, special list for children and pregnancy. And you can see this website has visits from more than 200,000 visits from 190 countries. So the European Society does not recommend for diagnosis the auscultatory devices unless automated devices are not available. These devices are not preferred unless the arm devices measurement is not possible. And please focus on this one. These very attractive, cuffless, wearable devices that are everywhere and everybody likes them, not recommended for diagnostic purposes for patients follow-up at the present time. And you can see here, last month, during the European Society of Hypertension meeting in Athens, the European Society of Hypertension Working Group published a statement on cuffless devices, very challenging devices, very promising devices for the future, but not yet. How to use home measurement? The optimal schedule is before seeing to the doctor, ask the patient to measure for 7 days. Take duplicate morning and evening readings after 5 minutes sitting rest, 1 minute apart. This is the optimal schedule. The minimum schedule is to take 3 days with 12 readings. If you have less than that, there is no valid information. And this is a study we published last week. This is based on 2,000 patients from Oxford, UK, from Athens, Greece, and from Finland, 3 countries. And you can see here, if your patient is asked to measure for 7 days, the first reading is high, the first double reading is high, the first day is high. So it's better to discard the first reading. And this is what the guidelines say. If you see a schedule of 7 days, discard the first day, calculate the average of all readings. Don't look at individual readings. They have very little diagnostic accuracy. And use the average, and should be, if it's higher than 135 or 85, this suggests hypertension. And this is the form we use to give to our patients to be back in the clinic. This is 7-day monitoring. And between visits, we ask them to measure once or twice per week or month. And these are forms you can download from the European Society of Hypertension website one page, how to do home blood pressure monitoring, one page, how to do ambulatory monitoring, one page, how to do office measurement. You put it on the wall on your clinic, the healthcare professional follows the steps, does the job properly. And the Stride BP has free of charge 3 interactive modules for healthcare professionals, half an hour each. If you do that, you know to do how perfectly perform office, home, ambulatory monitoring, 3 individual sessions. So this is my final slide and my conclusions. Ladies and gentlemen, home blood pressure monitoring is the only realistic solution for wide application of out-of-office blood pressure measurement in the 40% of the population which have high blood pressure. It is low cost. In fact, the users have decided to pay the cost, and it is the preferred method of most of our patients. It is the ideal method for follow-up of long-term untreated hypertension and has been shown to improve adherence to treatment and blood pressure control, which has been mentioned as a major issue by previous speakers. It must be performed with validated upper arm devices. We must employ an unbiased automated average, and we must get home blood pressure monitoring as the basis of the management of our patients of hypertension. Thank you for your attention.
Well, thank you very much, Professor Stergiou, for what a beautiful lecture. You still have like 3 minutes, so I want to give opportunity to the panel, this faculty, to maybe ask 1 or 2 questions before we get to the floor or to the audience here. Professor Shaheen, you have anything on home blood pressure monitoring for Professor Stergiou? Any question, Professor Gola, Professor Anastase Dzudie?
I mean, let me ask you, Professor, first, thank you very much, Professor Stergiou, for this excellent presentation, very illuminating lecture. I would like to ask about, is it fit for all patients to use the home blood pressure monitoring? What about the anxious patient? Is there any problem in these patients, particular management for this kind of patients?
This is a real problem to all clinicians. All clinicians who see patients with hypertension know that there are patients that are very anxious because they observe the variable nature of blood pressure. So I think it is up to healthcare professionals to train these people about the variability of the blood pressure, its behavior, its significance, and how to perform measurements. I would say that with proper advice, 95% or more of patients will do well. Those people who are not trained and see this random change in blood pressure, they get upset. I think it's up to us to solve most, but as you mentioned, not all the problems. Some patients are not good for home monitoring.
All right. Okay, thank you very much. So Professor Stergiou, you mentioned the issue of bias. Now, when Professor Shaheen talked about anxiety, you said that maybe through counseling, you can actually reduce it. So counsel your patient very. So my question is this: will proper counseling also reduce this risk of bias of patients choosing their value, telling them the importance of the values, how it can affect, titrating their medication, or so on and so forth, and the importance or the impact on overall well-being? Will it reduce this risk of bias?
I don't have data to answer this question.
Yeah.
As you imply, with proper advice and training of the patients, the problem can be eliminated.
Okay.
But maybe only few patients can correct this problem, because there are several studies that show that indeed patients tend to discard their high readings, which means that they underestimate the information which they give us, which is quite serious. So of course, the ideal is press a button, have the average, all the information. As you mentioned, probably training people will improve the situation, but we can't rely on that. If I want to discard my measurements in the office and I say I don't believe it, this is white coat or mass hypertension, we do need to have truly unbiased information.
Thank you very much. Professor Bella.
Yeah, maybe just a practical question, Professor Stergiou. That was a really nice presentation. One question that patients often ask me, I tell them morning, a pair of readings, 2 readings, evening. And then they would ask, say, okay, so morning, what time? Is it immediately I wake up? Is it before breakfast? Is it after breakfast? Evening, is it when I've just come back from work? Is it before I go to bed and all that? I'm not sure that there's very clear data as to when exactly within the morning and within the evening.
These are very practical information for patients and doctors. And I think it's amazing how many published papers are on this very simple question. I can tell you that if you look at the PubMed, you'll find 100 of papers looking on the schedule, how to do it. So in the morning, there is agreement. Wake up, go to the lower toilet, sit down for 5 minutes, before anything, before breakfast, just after going to the toilet, before drugs, sit down and take 2 measurements. There is agreement on that. Where there is confusion is in the evening measurements. In Asian studies, they take evening blood pressure before sleep. In European studies, we say evening, which means 6, 7, 8 o'clock. And there are some differences among the studies because of this difference. So I think the confusion is in the evening. In the morning, there is a clear agreement how to do it. But in the evening, most people prefer anytime relaxed at home after 6, 7, 8 o'clock. The Asian populations studies use that before sleep, which I think it's a little misleading.
Thank you very much, Stergiou. So, Professor Dzudie, any question from you?
No, not really for now, but
Okay. Right.
I agree that there were some data. There were some data on night dipping, on dipping using ambulatory. So I was using home blood pressure measurement. So I was wondering how that was done.
How they did it, yeah. So data on the dipping at night for home blood pressure monitoring. How do you get? Yeah.
Yeah. The devices that are used, the home monitors which are used for nighttime measurement, are automatically taking measurements every 2 hours after sleep and every 1 hour. So when you go to sleep, you take a measurement. So you're saying the device, I'm going to bed, and you wear it. After 2 hours, the device will take automatically 1 reading, after 1 hour, a second, and after a third. So take 3 readings, and you do it for 3 days. So it's not the same ambulatory monitoring. It is 3 readings for 3 nights, a total of 9 readings. And it gives a similar nocturnal blood pressure assessment as ambulatory monitoring, which actually is expected because both of them looked at the sleep blood pressure. And the great advantage is that these devices cost something like 100 euros, 120 euros, whereas ambulatory monitoring costs 1,000 euros.
Sure.
Sure. So cost effective. Thank you very much, Professor Stergiou. We just take some questions from the participants. So the first question here is a question from Ben Kamfak for discussion session. Say, which method is more precise in assessing left ventricular hypertrophy? Is it ECG or cardiac ultrasound? So Professor Dzudie, I think that question is for you.
Yeah, that's a very good question. I would say ECG is actually highly specific, but not sensitive enough. So, but at least it's the most available tool. So it is recommended to do the ECG in everyone. When it comes to echo, we need to be sure that the patient presents other symptoms or that the hypertension is severe or that there are other reasons to go for echo.
So in essence, ECG is a screening tool.
Yeah, sure.
So so and when you do an ECG, for example, you're having left ventricular hypertrophy with strain, inverted T waves, in the lateral leads, for example, because that such a patient, it will be better for you to do an echocardiography to look at the function of that patient.
Agree. Okay,
the second question also, I think, is for you, Anastase. Good evening, and thank you for presentation. He says, I'm a 50-year medicine student, and he wants to know, please, I wish to know reason why antiplatelets, clopidogrel, anticoagulant should not be given a patient with stroke, provided we are in rural area where there is no access to a CT scan to be able to differentiate between the two forms. So if we don't have access to a CT scan, why should we not give antiplatelets agents to stroke patients?
I think, thank you very much, Professor Dike. That's a very good question once more. And I think I will also address it to the panel. I don't know if anyone has a good answer for that. But for me, what I think is that the rationale of prescribing antiplatelets is based on the fact that we want to improve the condition if it was an ischemic stroke. But what if it is hemorrhagic and we aggravate the situation? So that's really the issue. We don't want to aggravate our patient. And there is no really strict criteria from the clinical point of view to say, okay, based on this, I can say this is a hemorrhagic, or based on that, I can say this is ischemic. The only thing to do is to do a CT scan, and then from there you can prescribe antiplatelets or anticoagulants. So in absence of any brain imaging, I would just say, for me, you better abstain from antiplatelets.
And I think it should be clear that really antithrombotic therapy, whether it is antiplatelet for a atherosclerotic stroke or anticoagulant for cardioembolic stroke, really does nothing about the stroke that has occurred. It's really about preventing recurrence.
Prevention,
And there is always the risk of also, even if it is an ischemic stroke, there's the risk of hemorrhagic transformation. So that, for example, like the atrial fibrillation guidelines actually give you a guide depending on the extent of the neurological damage, how many days you should wait before you initiate anticoagulation actually. So it is not automatic that you have atrial fibrillation, you come in with a stroke that I must start the anticoagulation immediately. In fact, if it's a light stroke, you should really wait. So I think that's the other additional information, apart from the fact that this could actually be a hemorrhagic stroke and you are going to make it worse.
That's good. And just to thank you very much, Professor Gola, and just to say that there seems to be overusage of antiplatelets in the continent. Remember the tissue study? And in the tissue study, which was the largest observational study for heart failure, in the continent, where we saw that aspirins were prescribed, so much, even up to about 81% of cases. So, and we should know that antiplatelets are not innocuous. Bleeding, we've seen patients have upper GI hemorrhage, from such. So I think there should be proper indication, proper profiling of your patient, before using aspirin or antiplatelets. And like Professor Gola said, more for secondary prevention, Okay, there's another question here. He said, why is it important to pursue an intervention that gives only 3 millimeters mercury improvement in blood pressure? I'm sure that is for me. So that is at the CRUISE study. In the CRUISE study, let me recap. that we compared amlodipine hydrochlorothiazide in one arm, amlodipine perindoprine, that's an ACE inhibitor in another arm, and perindoprine hydrochlorothiazide. And we found out that the amlodipine combination were better in reducing mean ambulatory systolic blood pressure. That is not office blood pressure. So it's ambulatory blood pressure. So when we looked at office blood pressure, we're looking at values over 20 millimeters of mercury. You understand? Reduction, overall reduction. And our differences were up to 8-10 millimeters of mercury or more. So that is ambulatory blood pressure. So 3 millimeters of mercury ambulatory blood pressure is not a joke. Okay, so I think this is for Professor Stergiou. What is the difference between ambulatory blood pressure and home blood pressure monitors? Say, I don't understand.
I think it's a question which is really important to realize, because these methods are similar. They are similar in that they both provide many measurements, and they are all away from the office. So they are supposed both to be able to detect white coat and mass hypertension, but they are quite different methods in that they provide different information on blood pressure profile and behavior. For example, ambulatory monitoring will tell us about blood pressure at work. And some people have a stressor of pressure at work time. They also give us information about nighttime, which is not provided by home. So the truth is that these methods are rather complementary rather than competitive. And if you use only one of them, you may miss some cases of elevated blood pressure. So although ambulatory blood pressure might mean ideal from what I said, it has the advantage that it's only one day, and our days are not the same. Our nights are not the same. So tomorrow I had a bad day for some reason or without a reason. So one day is not enough information. So these methods are very similar, but they have also distinct differences. And ideally, it's difficult to ask that. I would like to have both, to have a full picture of an individual.
Yeah.
And also another short comment. When you have a first patient, no drugs, IBPM is ideal. You put it today, you have it tomorrow, you have 100 measurements, you get all the information. But when I have a treated patient, when I see him again and again, he takes measurements, then home blood pressure is preferred. So each method has differences and special advantages.
Thank you very much. Thank you. So maybe we don't have any other questions. Can see, let me see, there just one came in to the chat. Okay, so there's a question here. It is said that there is greater genetic variability with an ethnicity than between ethnicity. How can we reconcile this with the differences in hypertension phenotype between blacks and whites? Okay, maybe that's a question for me, but before I try it, any comments from the panel? Professor Gola, you want to?
No, just read the question again. I didn't get it very clear.
So he said that there is greater genetic variability with an ethnicity than between ethnicity. How can we reconcile this with differences in hypertension phenotype between blacks and whites? Greater genetic variability with an ethnicity than between ethnicity raises.
Okay, Dike, you give it a go.
Good. Okay, so in terms of hypertension, and I'm very happy, Professor, I mentioned it, that it is not only genetically driven. It's driven, there's modulation by the environment. But genes, I believe, play quite some significant role in hypertension management. I've been in a clinic, let me say it this way, whereby we have African Americans and Caucasians And most times, you have the blood pressure of the Africa. I've seen there in such clinic 180, 110, even when they claim they're taking their medications. But a number of times, you don't have that level of blood pressure in the Caucasian population. So I believe one thing, that the Black population genetically, because we don't excrete as much sodium, and maybe because of other factors, it might be from the endothelium, we don't know, tend to run a more severe course and even complications of hypertension, because there are different studies that have shown, even when the Black and white population have the same environment in terms of Medicare and everything, complications like left ventricular hypertrophy, heart failure, hypertensive heart failure, chronic kidney insufficiency tends to be more in the Black population. So to me, in terms of genes, there is variability when you compare one race, to the another race. And that is what translates into the phenotype. But the phenotypes are modulated also by environmental factors. And that is the argument about inequality when they talk about the US. So some people don't believe that genes is what drives hypertension. They believe that it's social deprivation. But for me, I believe that there's some genetic predisposition, inclusion to environment. So in terms of genetic differences, it is different races, and that is why I mentioned the Lidus hypertension. Why is it that in about 5.9% of South Africans, when you look at their hypertension, they have low renin and they have low aldosterone, and they still have high blood pressure. And most of those blood pressure is resistant to treatment, except to use amiloride to treat that population. So there is some genes, and the differences in genes is different races, and that is what will drive the phenotype, but modulated also by environmental factors. That is what I feel. I don't need Professor Stergiou or
and I think there is analogy in other disease conditions. For example, if we look at the rheumatic fever, rheumatic heart disease spectrum, the peak age group for rheumatic fever is the same in all population, because it's the peak age group for strep infection. But even when there was a lot of rheumatic heart disease in the Western world, manifest clinical rheumatic heart disease occurred much later in life. When in Africa, you get a kid with clear-cut rheumatic mitral stenosis at 5 years or so. So, I mean, obviously, when you are talking at population level, there are generalizations, but there's clearly racial difference in certain things and in response to certain things.
Sure. All right. Thank you very much. Thank you. So maybe just last word before I hand over to Professor Shaheen. You are going to round off for us. Professor Anastase, any last words from you, or just a statement or a comment, and then maybe then over to Professor Stergiou or Professor Ogola, then Professor Stergiou. Then we hand over to Professor Shaheen to round off this session.
No really a major comment from my side. I think this was a very good webinar, and the quality of presentations were good, and I'm happy with it. This should be repeated.
Thank you very much. Thank you. Professor Gola?
Just to say thank you very much, especially to Professor Stergiou, and you are welcome to join us again and again and again. We shall keep on inviting you. Thank you.
Thank you, sir. Professor Stergiou, before we hand over to Shaheen.
I very much enjoyed this meeting and the discussions. I just want to say that we know a lot about blood pressure. We have an amazing source of information, data, huge studies, but this does not fit well with our performance. So the problem we do have, it is not that we don't know, it's not that we don't get it right. So what we know, what we have, we can do much better. So we have an implementation issue, and this is what we should strive about. Thank you for inviting me.
Thank you very much, sir. Thank you for coming. So Professor Shaheen, over to you now to round off for us.
Thank you very much, Professor Ojji, for this wonderful moderation of this important webinar. I think I would end up by having 5 take-home messages from the 5 lectures. The first from Professor Ogola was the high prevalent rate of hypertension among Africans, with the rate of diagnosis, treatment, and control. And definitely this has been very much apparent among African countries. The second message is about the high rate of hypertension-mediated organ damage and the importance of early diagnosis of these subtle changes that might occur in this organ damage. And again, this has been beautifully presented by Professor Dzudie. And about the lifestyle modification, how important is it? And it reduces the blood pressure and reduces mortality. And again, it is cost effective and should be accompanied with pharmacological treatment in all patients and even in prevention of hypertension. The fourth message from Professor Ojji is the importance of selecting suitable drugs for African patients. The calcium channel blockers and the thiazide diuretics perhaps may be the recommended treatment in African hypertensive patients. And the fifth and last message was from Professor Stergiou about the home blood pressure, the importance of this home blood pressure practice in diagnosing hypertension, adjusting the blood pressure, in improving the patient compliance, better controlling the blood pressure, and of course, differentiating white coats from muscle hypertension. And I think the recommendation also to use properly validated devices is very important. So I think we have learned a lot from this nice presentations, and I thank the PASCAR for arranging such a webinar, the Hypertension Task Force and the Prevention Task Force. And we also would like to thank OMRUN, and we'd like to thank the team, the PASCAR team, for arranging for this webinar. I know it has been a hard work to arrange for this, and thank you for all the faculty, and thank you for the audience for attending such a great event. Thank you very much.
Thank you very much, sir. Thank you everyone for coming. Yes.